The following podcast is part of a certified educational activity titled Turning the Tide in Gastric Cancer Management, Integrating Modern Systemic Therapies Across the Disease Continuum for Community-Based Clinicians. Access the entire activity and complete the post-test at peerview.com/KFF860. Downloadable slides and practice aids are also available.
Good day. I want to thank you and welcome you to this talk, which is titled Turning the Tide in Gastric Cancer Management. And the goal really is to discuss the current state-of-the-art standard of care targeted therapies and biomarker testing and how we identify the optimal treatment for our patients, as well as specific toxicity management issues. My name is Jeffrey Koo. I'm a GI medical oncologist from Memorial Sloan Kettering. My research and patient care focus on patients with upper GI cancers, and it is my pleasure to be with you today. These are the goals for today. A, to enhance your knowledge about the latest clinical trial evidence. B, to equip you with strategies for biomarker testing and identifying the right treatment. And finally, to also provide you with tools for patient-centric and adverse event management. Module 1 focuses on building the Alliance for Personalized Care in Gastric Cancer, and that refers specifically to pathology review as well as biomarker testing. Now, I think all of us recognize that globally, esophageal gastric cancer is a source of major morbidity and mortality, although clearly there are differences in incidence, with this being a comparatively rarer cancer in the US as well as Western Europe. But despite that, the incidence is actually increasing globally, and it's projected to increase from 2020 to 2040. And we see in the cartoon here on the right that even from the period from 2022 to 2025, unfortunately, there is an increase in the estimated number of deaths on a global basis. So this is certainly a very significant problem. Thankfully, the future is changing, and the era of giving cytotoxic chemotherapy alone has ended. We now have multiple biomarkers that are part of routine testing that inform treatment choices for our patients. Specifically, we test for a PD-L1, which is present in up to 60 to 70% of tumors, and this clearly identifies patients whose tumors are more likely to benefit from the addition of immune checkpoint inhibitors to chemotherapy. The MSI, or MMR deficient population, is critically important to identify. This comprises 3 to 4% of patients in the metastatic setting, 7 to 8% of patients in the locally advanced setting. And as we all know, patients with such tumors have disproportionately high response rates to immunotherapy, and a very significant proportion, maybe even the majority of patients in the metastatic setting can actually be cured with immune checkpoint inhibitors. HER2 by now is a very well-established biomarker. It's present in up to 20 to 25% of tumors, depending on the location, whether it's GE junction or distal stomach. And we know that survival is clearly improved with the addition of anti-HER2 therapies, namely trastuzumab as well as trastuzumab deruxtecan. And the newest kid on the block is Claudin 18.2, which is expressed in nearly 40% of tumors, and there is now an FDA-approved therapy directed against it in the first-line setting. So the first question is, how do we test for microsatellite unstable tumors? There are several tests that can be applied, and which tests do we order and in what sequence? Well, as all of us know, the most commonly used test in the first line of testing is immunohistochemistry for each of the 4 MMR proteins. The benefit of this approach is that there is a quick turnaround time, and it establishes in a very binary fashion whether there is retention or loss of each MMR protein. The major deficit of this approach is that it can miss defective alleles that retain antigenicity and expression. In other words, it's a non-functional protein that makes the tumor cells appear like it's MMR proficient. Now, this deficit is overcome by PCR testing, which really does test for microsatellites. It will therefore detect the 5% of cancers that are actually MMR defective but have retention of the protein. It's extremely sensitive, but is much more time-consuming and should be avoided in cases when there is low tumor cellularity tumors, because that can lead to a false negative result. Finally, we have the one-stop shopping of comprehensive genomic testing through next-generation sequencing. This will give us information about tumor mutation burden, which should be very, very high for these tumors. It can also give us specific information about which specific MMR gene is defective. And in some of the more modern assays, which separate out somatic, so tumor mutations, from germline mutations, it can also directly identify patients who have underlying HMPCC or Lynch syndrome. The issue, of course, is that it's a longer turnaround time and is significantly more costly than immunohistochemistry. But each of these tests has a role to play, and certainly the initial testing that all patients should undergo is IHC. Assessing HER2 positivity in esophagogastric cancer is also now a well-studied topic, but there are significant differences compared with other tumors such as breast cancer or even other GI cancers such as colorectal cancer. In gastric cancer, the heterogeneity of staining is much greater. So in other words, some cells are HER2 positive, while those surrounding it can be HER2 negative. As a result, the possibility of false negative testing is higher. In addition, there is a very specific pattern of HER2 expression in gastric. So the protein is absent in the luminal membrane of the tumor cells, and so it is therefore expressed in what's called a basolateral pattern, so it's not completely circumferential. So it's critically important that these differences be recognized and that an experienced pathologist perform HER2 testing for esophagogastric cancer. Now, there are also important considerations when it comes to how we test for HER2. So clearly, the standard of care that all of us are familiar with is immunohistochemistry and FISH testing, and that actually should be performed in a hierarchical way. In other words, you start with immunohistochemistry first, and you default to FISH only if it's HER2 IHC2+, which is equivocal. Now, I'll go through the advantages and disadvantages of this approach. The advantage, of course, is that it has long been the standard of care. IHC has a rapid turnaround of several days, and overall, this is the most cost-effective approach, and it is widely available. Now, the disadvantages is that this is frequently a standalone test and frequently has to be sent out to a central pathology lab, which therefore takes longer to return. And of course, this approach misses tumor heterogeneity, which we've already talked about in the previous slide. The next approach is next generation sequencing. Again, it's a one-stop shopping. A benefit of NGS is that it also allows for the detection of potential resistant variants, although currently there are no standard clinical applications for this information. Disadvantages relative to IHC and FISH is that, of course, there's a longer wait time. So with commercial panels, it still takes 2 to 3 weeks, much higher cost. And NGS has a lower sensitivity than FISH for detecting HER2 positivity. And just like IHC and FISH and other tumor-based techniques, it can miss tumor heterogeneity. Finally, we have circulating tumor DNA or ctDNA. Of course, the benefit of these liquid biopsies is that they do not require a tumor tissue or biopsy. You can perform ctDNA testing at multiple time points. It is clearly not confounded by tumor heterogeneity, which is a major advantage. And it can actually detect the real-time emergence of resistance mechanisms, which again currently has no standard of care applications. Disadvantages of ctDNA, again, is that it's relatively expensive. The turnaround time is typically more than 1 week. At this point in time, we also don't fully understand the sensitivity and specificity characteristics versus standard IHC and FISH, and this remains something that's being defined by ongoing studies. Finally, the use of ctDNA is generally not accepted as a screening assay for most experimental options. So a patient who's found to be ctDNA positive on the basis of HER2 positive on the basis of ctDNA alone would have to be retested using one of the conventional methods. So the bottom line is that ctDNA or liquid biopsy certainly have the potential to become a very powerful tool even in the near future. But for now, they really should be only used as an adjunct to complement standard IHC and FISH or next-generation sequencing. This last slide emphasizes something that we all know. Based on a survey of patients, there is strong interest for patients to undergo testing, to understand the results of the test, to understand the therapeutic implications, as well as whether there are implications for family members. So certainly all of us as physicians treating these patients should absolutely perform the testing that I mentioned because it clearly directs treatment options. In this module 2, we will talk about the use of immune checkpoint inhibitors in patients across the spectrum of disease. We'll start initially with patients with advanced esophagogastric cancer. So we'll start also with a case vignette. This is a 58-year-old man who presented with mild dysphagia and a 5-kilogram weight loss. His primary care physician requested an endoscopy, which showed a tumor at the GE junction. The biopsy showed a poorly differentiated GE junction adenocarcinoma with signet ring cell features. His imaging then revealed 2 liver lesions, large gastrohepatic lymph nodes, and thickening at the GE junction. So the first question we should all ask is what additional information would be required to help us select the optimal treatment for this patient? So he subsequently underwent standard biomarker testing. The tumor cells are HER2 negative, 0 by immunohistochemistry. The tumor is microsatellite stable with a tumor mutation burden of 5 mutations per megabase. The PD-L1 CPS is 11, and the tumor cells are claudin 18.2 negative. The only alteration found was a p53 mutation. Patient otherwise has no comorbidities that would be a contraindication for immune checkpoint inhibitor. So the question then is, what treatment would we offer the patient? And I think we'll have a better understanding of the response to this question after we go through the next section. So here I put up the 3 phase 3 studies that have led to FDA approvals of immune checkpoint inhibitors in the first-line setting in the U.S. The Checkmate 649 study was actually sequentially the first study that looked at nivolumab in the first-line setting for tumors of the esophagus, GE junction, and stomach. The Keynote 859 study then looked at pembrolizumab in patients with GE junction and gastric cancer. And most recently, the Rationale 305 study looked at tislelizumab in that same population. So the top-line overview is that essentially all 3 of these studies and all 3 of these drugs have largely comparable benefit. The addition to chemotherapy improves response rates, especially in tumors that are PD-L1 positive, and that depends on the cutoff of 1 or 5 or sometimes even 10. In addition, there's an improvement in progression-free survival that's largely similar based on the hazard ratio, and ultimately all 3 of these drugs also lead to overall survival improvements with a magnitude of benefit in the range of about 2 to 4 months. In addition, there are some other promising immunotherapy drugs that are currently being looked at. Compassion 15 is looking at a drug called cadonilimab, and this is actually a bispecific antibody of PD-1 and CTLA-4. Certainly, the results are extremely encouraging in phase 3 evaluation. In addition, there's a combination of that's called DOM and ZIM, and this is actually an anti-PD-1 with an anti-TIGIT antibody. And in a single-arm phase 2 study, the results were very encouraging, and that led to the STAR 221 study, which is a phase 3 study evaluating this combination versus nivolumab FOLFOX. That study has completed accrual, and we eagerly await those results. So coming back to the initial case, again, we now have a PD-L1 positive tumor that's HER2 negative, as well as claudin 18.2 negative. So certainly for this patient, I would select an immune checkpoint inhibitor with chemotherapy. I typically offer nivolumab with FOLFOX because the every 2-week dosing of nivolumab meshes very well with the every 2-week dosing of FOLFOX. Although, again, I think all of the immune checkpoint inhibitors are largely comparable. In terms of organ function, of course, it's important to make sure that the patient has normal LFTs and renal function prior to receiving these treatments, although immune checkpoint inhibitors can technically be given over a relatively wide range of organ function values. I think all of us are aware that immunotherapy can cause significant toxicities, including pneumonitis, colitis, dermatitis, thyroid issues, and a host of other issues. So patients really have to be comprehensively followed with lab work and symptom assessment at every single visit. An additional question, what if the patient has a different CPS? If the CPS is 0, then I would say that there is no role for immune checkpoint inhibitors, and indeed, the FDA approval and the NCCN guidelines recommend chemotherapy alone for those patients. Right now, NCCN guidelines recommend immunotherapy with chemotherapy for any tumor that is PD-L1 positive, and PD-L1 positivity is defined quite loosely. So if a patient has a CPS 3 tumor, I would still recommend immunotherapy with chemotherapy. Moving to the next stage, we now are looking at immunotherapy in earlier stages of disease. So again, we'll start with a case. This is a 65-year-old woman who presented with a 3-month history of worsening dysphagia. Ultimately, her workup diagnosed her with a locally advanced stage 3 G junction adenocarcinoma. Her performance status is 0, and based on current data, you and the patient decide to incorporate immunotherapy into her curative intent surgery. So therefore, what options would you discuss with her? Would one consider preoperative therapy or adjuvant therapy? And what are some of the factors that would lead you to make your final recommendation? Again, let's review the available data and come back to this case at the end. So the rationale for considering the addition of immune checkpoint inhibitor with something like preoperative chemoradiation comes from multiple data sets, all of which suggest that following radiation, there's actually upregulation of multiple immune checkpoint molecules, including PD-L1 expression. So the thought is that potentially this is a survival mechanism for the cancer cells. So treatment with a PD-1 or PD-L1 inhibitor might therefore be beneficial in this context. At the same time, the question of the timing of immunotherapy is highly relevant. This cartoon really highlights this very elegantly. The proposed rationale for giving adjuvant immunotherapy is shown at the top. A surgeon removes the tumor, but there are small tumor deposits left behind, micrometastatic disease. At that point, we then treat with an immune checkpoint inhibitor, which results in the activation of a smaller repertoire of T cells, which then potentially leads to fewer and less diverse T cell response. On the other hand, the rationale for giving preoperative immunotherapy is that having the tumor in situ, having the tumor present, may actually be necessary for antigen stimulus. And that, again, is illustrated very nicely in this cartoon. When you treat a patient in this setting, you lead to the activation of many different T cells with a much wider repertoire that may provide for a more effective anti-cancer response, even after the surgeon has removed the majority of the tumor, leaving behind small micrometastatic disease. So this would be the arguments for both approaches. Well, what are the data to support either? So we start, of course, with Checkmate 577, and this, as a reminder, was a study that originally enrolled patients with esophageal cancer who had completed trimodality therapies, in other words, chemoradiation and surgery, but who had residual pathologic disease, i.e., these patients did not achieve a pathologic complete response. They were then randomized in a 2-to-1 fashion to 1 year of nivolumab versus placebo. Importantly, both adenocarcinomas and squamous cell cancers were enrolled, but this was a stratification factor, as was PD-L1 expression. So more longer-term follow-up was presented at ASCO 2025, and we know that with longer follow-up, there is maintenance of the disease-free survival. We see a very nice separation of the curves. At the same time, there's also maintenance of distant metastasis-free survival, again, with ongoing separation of the curves. There was a trend towards improvement in overall survival. We see a clear separation. However, the hazard ratio was relatively high, 0.85, and the p-value was 0.11, which did not meet statistical significance. Now, what's critically important is the subgroup analysis. As we've always known, squamous cell cancers are more likely to benefit from immunotherapy. And indeed, if you look at the histology, the hazard ratio for squamous cell cancers was 0.72, whereas it was 0.92 for adenocarcinomas in terms of overall survival. So suggesting that squamous cell cancers are much more likely to benefit than adenocarcinomas. At the same time, if we look at PD-L1 CPS, we also see clearly that tumors that have a PD-L1 CPS of 1 or more have a lower hazard ratio than those that are less than 1, which actually were the minority of patients. But in those patients, there really did not seem to be benefit. So again, while this is not statistically significant, I think many of us have incorporated these data to the extent that we would consider adjuvant immunotherapy for patients with squamous cell cancers, but might not consider that approach for a patient with an adenocarcinoma, especially an adenocarcinoma that's PD-L1 negative. Now, since the time of Checkmate 577, the standard of care has really changed. So as a bridging discussion, it's important to mention the ESOPEC study. And this is a German study that randomized patients to perioperative FLOT chemotherapy versus preoperative chemoradiation with carboplatin paclitaxel. And I think as all of us know, FLOT essentially blew cross out of the water. It was associated with improved progression-free as well as overall survival. And actually, quite remarkably, even had a higher pathologic complete response rate than cross-chemo radiation. More recently, updated data about the recurrence pattern was presented. Recurrence-free survival was also improved with FLOT versus cross-chemo radiation. And importantly, we see that distant metastasis-free survival is improved with FLOT relative to cross, as one would expect from more effective systemic therapy. At the same time, local recurrence rates were actually comparable between both groups, suggesting that the omission of radiation really does not lead to a higher risk of local recurrence. So based on these data, essentially overnight, perioperative FLOT has become the standard of care for any patient with localized esophageal GE junction as well as gastric adenocarcinoma. So in this context, we present the results of the phase 3 Matterhorn study, and this was a study that added durvalumab, an anti-PD-L1 antibody, to perioperative FLOT for patients with GE junction and gastric cancer. Primary endpoint of the study was event-free survival. So firstly, the addition of FLOT to chemotherapy significantly improved pathologic complete response rates, which went from 7 to 19%. And in terms of the primary endpoint, EFS, we see that there's a clear improvement in EFS with the addition of durvalumab to FLOT, essentially establishing this also overnight as a new standard of care in patients with locally advanced disease. In terms of subgroup analysis, it appears that everyone benefits, and somewhat surprisingly, but happily, the majority of tumors that were tested actually were PD-L1 positive. Only a small percentage of tumors were PD-L1 negative, and even those seem to benefit from the addition of durvalumab to FLOT. More recently, overall survival data, which is, of course, a critical secondary endpoint, were also presented at ESMO 2025. And this also was positive. So we now know that the addition of durvalumab to FLOT also improves overall survival with a hazard ratio of 0.78 and a p-value of 0.021, which translates at the 2-year mark to an improvement in 5.1 months in terms of overall survival. So very reassuringly, the addition of durvalumab to FLOT really did not compromise the ability to administer chemotherapy. And similarly, there were no known or synergistic toxicities with the combination of durvalumab FLOT. All of the toxicities were those that were already well established with immune checkpoint inhibitors. So with this in mind, we come back to our patient with the GE junction cancer who has an excellent performance status. So given all of the data, again, we've certainly moved away from chemoradiation, and FLOT would be considered the standard of care. But as I just showed, Matterhorn was a clear winner, and the addition of durvalumab to FLOT will now be considered the standard of care. In terms of other additional questions, the significance of a pathologic complete response, there are other separate data which show that patients who achieve a pathologic complete response to systemic therapy alone without radiation actually do very, very well. They have more than an 80% chance of being cured. And certainly, I think a major unanswered question moving forward is whether we can use ctDNA in this setting to guide treatment or maybe potentially to de-escalate treatment. But these are all ongoing strategies that are being explored. In this module, we will talk about other targeted therapies that can be added in the first-line setting for patients with esophageal gastric cancer. The first section will be focused on HER2-positive tumors. So this cartoon very elegantly summarizes the various therapeutic options targeting HER2. On the left, we have single epitope antibodies. Of course, in this class is trastuzumab. We also have pertuzumab, which binds to a different domain. And the mechanism is that these antibodies lead to internalization of the HER2 molecule as well as engagement of ADCC. The next major class that has created a significant impact in this disease are antibody drug conjugates. So in other words, strong cytotoxic chemotherapy drugs conjugated to anti-HER2 antibodies such as trastuzumab. And the most notable member of this class is, of course, trastuzumab deruxtecan. We also have TKIs that directly bind to the tyrosine kinase domain of HER2. And finally, we have bispecific antibodies The most notable of these is zanidatamab, which is actually a biparatopic antibody, which means that each arm binds to a different domain of HER2. And I will discuss this briefly at the end of this section. So we will start with the TOGA study, which was the original study in 2010 that established a benefit for any targeted therapy in esophageal gastric cancer. And in this study, trastuzumab was added to HER2-positive gastric cancer and significantly improved overall survival. Now, an important point of this study was that it initially enrolled all tumors that were HER2 amplified, but in the subsequent subgroup analysis, we know that benefit is really restricted to tumors that are either IHC3+ or IHC2+ and FISH amplified, which is now the current definition of HER2 positivity. You'll see in the subgroup analysis that the small number of tumors that were FISH positive, but IHC 0 or 1+ really did not derive any benefit. So at the time, trastuzumab was approved in the US based on the intention to treat population, but in Europe, it was approved based on the IHC3+, IHC2+ FISH positive population, and that is now the population that these treatments are restricted to. Of course, we move ahead to KEYNOTE-811, which added pembrolizumab to the combination of trastuzumab and chemotherapy, and that ultimately improved response rates as well as progression-free survival and overall survival, and these are based on the most updated data. We see also that response rates are improved with the addition of pembrolizumab to trastuzumab and chemotherapy, as is duration of response. Now, importantly, the outcomes were better in the CPS 1 or more subgroup, and that actually comprised 85% of the patients who enrolled on this study, so that in November of 2023, the FDA actually narrowed their approval for pembrolizumab with trastuzumab and chemotherapy and restricted it only to tumors where the PD-L1 CPS is 1 or more. Now, an important mechanism of resistance that we now know from multiple data sets is that up to 30% of tumors that are initially HER2 positive can lose the HER2 protein at the time of progression on trastuzumab-based therapy. In addition, there are also the emergence of KRAS and PIK3CA alterations that can lead to resistance. With that in mind, we now focus on the novel anti-HER2 therapy, trastuzumab deruxtecan, and this is an antibody-drug conjugate of trastuzumab with a topoisomerase inhibitor, and there are several potential advantages relative to older generation ADCs. First of all, deruxtecan is a very high-potency payload. There's a very high ratio of trastuzumab to payload molecules. There's about 8 chemotherapy molecules per trastuzumab, and there is also the potential for a bystander effect, and this is where deruxtecan can diffuse from a HER2-positive cancer cell into a neighboring cancer cell, which could potentially be HER2-negative because of the heterogeneity of HER2 expression in esophageal gastric cancer. And so in gastric cancer, this bystander effect may be particularly relevant and important. So there are several previous studies that I think many of us are already familiar with. Destiny Gastric 01 is initially established T-DXd as a treatment in the third-line setting and beyond in East Asian patients. Subsequently, Destiny Gastric 02 evaluated T-DXd in a U.S. and Western population in the second-line setting. I would note that an important distinction of Destiny Gastric 02 and all of the studies that have come since is that a post-trastuzumab pre-treatment biopsy is required to confirm HER2 positivity because, again, in 30% of patients, HER2 positivity is lost at the time of progression on trastuzumab. All of this leads to Destiny Gastric 04, which was a randomized global study that evaluated T-DXd versus the standard of ramucirumab paclitaxel in the second-line setting. And again, patients required a pre-treatment biopsy to confirm HER2 positivity. Primary endpoint of the study was overall survival. So these data were presented at ASCO 2025 and were published simultaneously. And there's clear benefit and superiority of T-DXd over the previous standard of ramucirumab paclitaxel in patients with HER2-positive tumors. In addition, progression-free survival as well as response rates are also improved. Turning to toxicities, at the end of the day, T-DXd is a cytotoxic chemotherapy drug, and it has all of those toxicities, including fatigue, myelosuppression, nausea, and vomiting. And of course, a toxicity of special interest that we all need to be aware of is interstitial lung disease, which has been seen in multiple studies of T-DXd across all solid tumors. The incidence is typically about 10%, and in this study, it was 13.9%. The majority were grade 1 and 2, although unfortunately grade 5 events are noted. So therefore, it's absolutely important to be on the lookout for this toxicity and for patients to be similarly aware of the possibility. Otherwise, a cardiac toxicity from T-DXd was thankfully very uncommon. In addition to Destiny Gastric 04, there are other ongoing studies. So Destiny Gastric 03 actually looked at multiple different combinations of T-DXd with chemotherapy, with immune checkpoint inhibitors in the first and second line setting. And several arms have been presented. In addition, specifically, Arm D looked at T-DXd at the standard FDA prescribed dose in esophagogastric cancer of 6.4 milligrams per kilogram, with full dose 5-FU capecitabine and pembrolizumab. And Arm F essentially looked at dose-reduced T-DXd along with dose-reduced capecitabine. Looking at the waterfall plot as well as the Kaplan-Meier curve, you'll see that the response rates as well as survival data are encouraging for both of these arms. And toxicities were certainly reduced with a lower dose of T-DXd and a lower dose of capecitabine. So on the basis of Destiny Gastric 03, Destiny Gastric 05 is ongoing. So we are now moving T-DXd into the first line setting. And this is a phase 3D study that's comparing T-DXd with and chemotherapy with or without pembrolizumab versus chemotherapy and trastuzumab with or without pembrolizumab. I would note that an important feature of this study is that in the experimental arm with T-DXd, the chemotherapy consists of a fluoropyrimidine alone with omission of the platinum drug, whereas in the control arm, patients receive a fluoropyrimidine platinum doublet. So the question here really is whether moving T-DXd into the first line can allow us to avoid the use of platinum drugs in the first line setting. In addition, there are other studies that are looking at T-DXd. The Artemide study is combining T-DXd and chemotherapy with a bispecific against TIGIT as well as PD-1. And finally, there is an ongoing phase 1 study that's combining T-DXd with a drug called valimidostat, which is an inhibitor of EZH1 and EZH2. And the thought is that this drug can potentially potentiate or increase the efficacy of deruxtecan payload. And this is being looked at in a phase 1, phase 1b study in patients. Now, turning to an important topic, which is toxicity management. Again, T-DXd at the end of the day is cytotoxic chemotherapy, and it's important for us to be mindful of this. And I think an underappreciated toxicity is nausea and vomiting, which is relatively substantial. So patients, when they receive treatment, should receive aprepitant as well as palonosetron. They should certainly be made aware of the possibility of post-treatment nausea and should have antiemetics such as ondansetron, olanzapine, and maybe even dexamethasone available. So providing patients with multiple options that they can use at home is very important. In addition, as previously discussed, interstitial lung disease is something that we all need to be aware of, and I think we also need to be very aware of the management. So the management is actually relatively straightforward. So for anything other than grade 1 interstitial lung disease, which is asymptomatic pneumonitis noted on imaging, the drug needs to be permanently discontinued. Patients need to be started on steroids. They need to be evaluated by a pulmonologist prior to starting on steroids to rule out other etiologies. But focusing on grade 1 pneumonitis, this is the management algorithm. In patients with grade 1 findings, in other words, radiographic findings and a complete absence of symptoms, steroids should be considered. And if the symptoms resolve within 28 days, in other words, you repeat a CAT scan and the inflammatory changes are gone, you can maintain the dose. If not, patients should be reduced by 1 dose level. And if the grade 1 interstitial lung disease lasts for more than 18 weeks from the last infusion, patients should be discontinued. In summary, there are currently 3 therapies that are approved for HER2-positive esophageal gastric cancer in the U.S. Of course, we have trastuzumab with or without pembrolizumab, depending on PD-L1 status. And in the second-line setting and beyond, trastuzumab deruxtecan is approved not only in the U.S., but also in Japan and the EU. Finally, in terms of new and emerging anti-HER2 therapies, I'm very pleased to report that at the time of this recording, there was a press release that a phase 3 study of zanidatamab is positive. These results should be shortly available. As a reminder, zanidatamab, again, is a bispecific, a biparatopic that binds to 2 different epitopes of HER2. And the phase 3 Horizon GEA-01 study was a study that compared standard trastuzumab and chemotherapy with 2 experimental arms, zanidatamab and chemotherapy, and a second experimental arm of zanidatamab chemotherapy and tislelizumab, which is the anti-PD-1 antibody. And hopefully, once these results are presented, this will represent a new treatment option for patients. Beyond zanidatamab, there are also newer generation ADCs. There are other bispecific antibodies, for example, HER2 in binding to CD3, and there are even emerging HER2 cellular therapies. So this leads us to our patient case. We have a 65-year-old man with an excellent performance status who, again, presents with mild dysphagia and weight loss. He undergoes an endoscopy, which shows a GE junction mass. The biopsy is consistent with a moderately differentiated adenocarcinoma. His imaging reveals 2 liver metastases, but no other metastatic disease. And on biomarker testing, we note that his tumor cells are HER2 positive, the IHC is 3+, so FISH is not required, and the PD-L1 CPS is 7. So in this context, in the current situation, what would we recommend? Pembrolizumab, trastuzumab, and FOLFOX, or trastuzumab and FOLFOX? And the clear answer from the Keynote 811 study, of course, is pembrolizumab with trastuzumab and FOLFOX. So, indeed, he initiates treatment with pembrolizumab and FOLFOX. His symptoms rapidly improves, and he regains all the weight that he lost. Imaging at 2 months reveals a very nice partial response. He then continues in treatment for about 8 months when one of the liver metastases begins to increase in size, and he develops recurrent mild dysphagia. So what is an immediate step that you take? And immediate here is the operative word. You start second-line trastuzumab deruxtecan. You biopsy the tumor or a liver metastasis, or you check ctDNA. So we talked a little bit about this, but again, 1/3 of tumors can lose HER2 positivity at the time of progression on trastuzumab, so a biopsy is important. We also discussed in Module 1 that ctDNA is certainly something that we can use as an adjunct or to complement standard tumor biopsies, but at this point probably should not replace them unless a tumor biopsy is absolutely not feasible. But in this case, because the patient developed worsening dysphagia, it's likely that his primary tumor is progressing. He therefore underwent a biopsy and it confirmed that the tumor cells were indeed HER2 positive. So in this situation, what treatment would you recommend? Trastuzumab deruxtecan or ramucirumab paclitaxel? And again, Destiny Gastric 04 gives us a very clear answer that T-DXd is superior to ramucirumab paclitaxel. The final section that I'll talk about will be the latest developments of Claudin 18.2. And as introduction, Claudin 18.2 or Claudin, this is a membrane protein that is found in the tight junction between cells. The tight junction basically causes cells to adhere to each other. It's important for maintaining the polarity of cells. It's also important for maintaining the impermeability of cells. And Claudin 18.2 particular, or the Claudin 18.2 isoform, is normally only expressed in stomach mucosa. It's also overexpressed, depending on the testing score, in approximately 70% of esophageal gastric cancers. It's also aberrantly expressed in a number of other malignancies. So there are actually now numerous, there's one approved, but numerous experimental treatments targeting Claudin 18.2. So on the left, we have monoclonal antibodies, including zolbetuximab, which is the FDA-approved drug. There are also newer generation antibodies with higher binding affinities. There's actually CAR T-cell therapy, and I'll discuss one positive CAR T-cell study against Claudin 18.2. There are several bispecifics that are being evaluated, including against immune checkpoint molecules such as CD47, PD-L1, and 4-1BB. And there actually are nearly too many antibody-drug conjugates to count against Claudin 18.2, all with slightly different chemotherapy payloads. So we'll start with the currently FDA-approved drug, which is zolbetuximab, and this is a naked antibody. And it was evaluated in 2 parallel phase 3 studies, Spotlight and Glow. Spotlight it combines zolbetuximab with a combination of FOLFOX, while Glow combines zolbetuximab with the combination of CAPOX. Both studies were positive and led to improvements in progression-free and overall survival. And so zolbetuximab was approved in combination with chemotherapy in the first-line setting in October 2024. It's important to note that it does require a companion biomarker diagnostic to define Claudin 18.2 positivity, which is IHC 2 or 3 plus in at least 75% of the tumor cells. And this was about 40% of the trial population. So this is a further breakdown in terms of the survival outcomes between Spotlight and Glow. Now, one thing I would note is that based on both of these studies, it appears that PD-L1 positive tumors are uncommon in Claudin 18.2 positive tumors. However, this is really due to patient selection because of the studies. And in reality, we know that PD-L1 as well as Claudin 18.2 naturally co-occur at the expected frequencies. Now, one thing that's important to note about both of these studies is that somewhat surprisingly, the addition of zolbetuximab to chemotherapy actually did not improve response rates for reasons that are unclear. And a major toxicity of zolbetuximab that patients have to contend with is significant nausea and vomiting. This typically occurs during the first several cycles and subsequently extinguishes and improves. But because of the nausea vomiting, there is a discontinuation rate. So therefore, it's really important to make sure that patients receive strong antiemetics both during but also after treatment as a delayed emesis regimen. There is also the possibility of an infusion-related reaction from zolbetuximab, so it has to be administered over approximately 6 hours. So as promised, this is a slide about Satracel or CT041. So this was a CAR T cell study that was presented at ASCO 2025, and specifically, this is a study performed in Chinese patients in the third-line setting and beyond, in which patients were randomized in a 2-to-1 fashion to receive Satracel versus standard of care chemotherapy. The study actually met its primary endpoint of improving progression-free survival. You see clear separation of the Kaplan-Meier curves from the beginning, and overall survival was also improved. However, concern about Satracel stems from the fact that unlike other CAR T-cell therapies, especially in hematologic malignancies, there does not necessarily seem to be significant durability. At most of the curves eventually, drop down pretty close to zero. In addition to that, we also have to worry about toxicities. 95% of patients, so nearly everyone, experienced some degree of cytokine release syndrome. Most of this was grade 1 and 2. Thankfully, ICANS, which is neurologic toxicity that can be associated with CAR T-cell treatments, was not seen with Satracel. So ultimately, whether there is a role for Satracel, especially in the early lines of therapy, remains to be seen. But this is the first positive study of a cell therapy in esophageal gastric cancer. So zolbetuximab is also now currently being evaluated in the Lucerna study. And this is a study that that is aiming to enroll patients to pembrolizumab and chemotherapy with or without zolbetuximab. So patients have to have both Claudin 18.2 positivity as well as PD-L1 positivity. The CPS has to be 1 or more. And again, it's targeting this dual positive population of tumors that are both PD-L1 as well as Claudin 18.2 positive. The other novel anti-Claudin 18.2 therapy that's worth mentioning is AZD0901. So this is an ADC that in phase 1 and 2 testing showed very promising activity, a response rate of nearly 50%, as well as encouraging overall survival data. And this has led to a phase 3 study, which is known as the Clarity Gastric 01 study, in which AZD0901 is being compared to standard treatment in the second line and beyond. So there's specifically a second line cohort, but there's also a third line and beyond cohort. And this phase 3 study is currently ongoing. So in conclusion, it is critical to test for important biomarkers in advanced disease, but also increasingly in localized disease to guide optimal treatment selection. Chemoimmunotherapy has been established as the backbone in the first-line setting for patients with advanced esophagogastric cancer whose tumors are PD-L1 positive. It has now also successfully moved into earlier stages, and the addition of durvalumab to perioperative FLOT and the use of nivolumab after trimodality therapy are now validated strategies. Thankfully, research is continuing at a very fast rate, and there are new targeted treatment options emerging, including T-DXd in the second-line setting for HER2-positive disease, zolbetuximab in the first-line setting for Claudin 18.2 disease, and numerous other treatments. Thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by independent educational grants from AstraZeneca and Daiichi Sankyo Incorporated. To access all materials for this activity, visit peerview.com/KFF860.